Welcome to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, the Executive Director of National Speaking of Women's Health, and I am happy to be back in the Sunflower House for the latest edition of the Speaking of Women's Health podcast. And on this episode, we are going to be talking about a very common, embarrassing, problematic problem that's not a normal part of aging: bladder leakage, the medical term being urinary incontinence. And it's a very important topic because millions of women experience involuntary bladder leakage, called UI, urinary incontinence. In fact, up to 1 in 3 women leak urine. Some, it may only be just a few little drops when running or coughing, and others may feel a sudden, strong urge to go to the bathroom before losing like a huge amount of urine. And some women have both stress incontinence and urge incontinence, which not surprisingly is called mixed incontinence. And this can be bothersome or just totally debilitating. And for a lot of women, the risk of public embarrassment keeps them from enjoying many activities with friends and family. Urine loss can occur also during sexual activity and can obviously cause tremendous emotional problems. Now, women, by virtue of their anatomy, having a vagina, having childbirth, increases the risk of UI. And the pelvic trauma of just carrying a pregnancy and then vaginal delivery can make things worse. But both men and women, because we all have bladders, can become incontinent, especially from things like neurologic injury, birth defects, stroke, multiple sclerosis that affects the spinal cord, and any physical problem associated with aging. And not surprisingly, older women experience UI more than younger women, but urinary incontinence and urinary leakage is not a normal part of aging. And your doctor or nurse or physician assistant or nurse practitioner can help you find some solutions. Now, no single treatment works for everyone, but many women can find improvement without surgery. And incontinence can occur because of problems with the muscles and or the nerves that control the release of urine. Now, obesity, which is very common, unfortunately, because of diet, high-calorie food constantly available, lack of physical activity, is associated with an increase in abdominal pressure, which can worsen incontinence. Fortunately, weight loss can dramatically reduce the severity of bladder leakage in many women. There, as I mentioned, are several different causes and types of bladder leakage. We're going to talk in depth about stress incontinence, urge incontinence, and mixed incontinence. And we have a lot of really good information on our website, Speaking of Women's Health, about bladder retraining, bladder irritants, pelvic floor therapy, ruling out bladder problems, infection, lack of enough hormones at the base of the bladder and the vagina, which is very common in women. If you haven't listened to my genitourinary syndrome, vaginal atrophy prior podcast in season 1, it would be a good time to review these, especially if you're a midlife or older woman. Now, when you have the urge to go suddenly for no real reason, and that strikes you and makes you have to run to the bathroom, this can be a problem called urge incontinence. Some women have problems at night, and it's really not normal to have to get up more than really one time at night to urinate. Sometimes you'll see the term or hear the term overactive bladder used kind of interchangeably with urge incontinence. And if you're leaking urine or constantly having urgency, which leads to urinary frequency, it can be really a vicious cycle. And urge incontinence is caused by the bladder contracting at all times because it's irritated and just wants to get rid of the urine. And disorders that affect the nerves or sensations, such as diabetes and other chronic neurologic problems, can make this worse. Now, nighttime symptoms of urination also can be due to other medical problems, such as sleep apnea or heart failure or dependent swelling in the legs. So the first time when the person lays down in bed, their body mobilizes all the fluid in the legs, and so the kidneys clean the blood, and hence there's more urine and you have to urinate more frequently. Now, stress urinary incontinence occurs when there's any increase in abdominal pressure with coughing or sneezing or laughing or lifting something heavy. And it's due to many factors and muscle weakness or nerve damage to the pelvic floor, especially around the urethra, lack of collagen and supportive tissue around the base of the bladder. Now, the risk factors for stress incontinence are pregnancy and childbirth, as well as weight gain, chronic constipation that requires bearing down. So really, everyone should avoid constipation. And I think my third podcast of season 1 last year was all on constipation. People that are involved in high stress, high impact activities like jumping and spiking. I've seen young Olympic athlete women have stress incontinence because of the constant jumping and spiking. There's also a strong genetic predisposition. So depending on what collagen and support and anatomy and muscles that you've kind of inherited from your family, you really should find out about any biological older females in your family and if they had any pelvic prolapse where their organs came down through their vagina. And this happens in 1 in 8 women. And I've examined many women that everything is normal, and then 6 months later, they call without really any other change in anything, something's coming down through their vagina, and it's very distressing, and it does require surgery. So when you get your yearly or every other year gynecologic exam, depending on your risk factors and your age and your symptoms and how often you've been previously screened, your women's health clinician should, with the gloved hands, doing the pelvic exam with the fingers in the vagina, palpating the uterus and the ovaries and making a sweep, also doing a rectal exam to check for any type of pelvic masses. You should be asked to do a Kegel or squeeze around the examiner's finger, like you're squeezing up and in, not bearing down. It's the same muscles that you would use if you were sitting on the toilet urinating and a fire alarm went off. You'd have to squeeze your muscles and jump up. Now, we don't want you to practice that while you're urinating because we want you to sit and relax and let the urine come out. But it's the same muscles that you would use to squeeze if you wanted to stop stool or gas or urine coming out any of the pelvic orifices. And the pelvic floor, the levator ani muscles form like a hammock that support the bladder and the pelvic floor. And those are the muscles that also contract actually when you have sexual climax. So keeping these muscles strong is very, very important. Now, unfortunately, a lot of midlife women have both stress incontinence as well as urge incontinence, particularly as their estrogen levels fall. And there are other types of incontinence. There can be, as we mentioned, the overactive bladder, which may not cause leakage, but just cause lots of interference with your daily life. Functional incontinence can occur because of physical disabilities or external obstacles to getting to the restroom, or any kind of problems in thinking or communicating that prevent a person from reaching the restroom. Overflow incontinence can happen when there's just urine that leaks out because the bladder is so full and distended. And sometimes there's obstructions. In men, it can be a big prostate, it can be pelvic tumors, big fibroids. There can be transient urinary incontinence that just occurs because of some acute situation like a bladder infection or a new medication or, a bad cold with constant coughing. So if you have bladder leakage, how should this be evaluated? Well, the first step is to see a clinician who has some interest and experience. Many gynecologists specialize in the female reproductive tract and childbirth. We have a class of specialists called urogynecologists that have special training in pelvic prolapse and urinary incontinence, recurrent urinary tract infections. And we have some urologists that specialize in female urology, not that they're females, but they could be male or female physicians that have special interest in female incontinence. There's also a panoply of other folks in the healthcare field, from nurses and advanced practice providers, as well as female physical therapists that can help retrain the pelvic floor. A lot of times, retraining the bladder is needed. If the bladder has not been working for a while for whatever reason, there's been a prolonged catheter, there's been infection, surgery, injury, or just from getting into bad habits. Sometimes you need to retrain the bladder, just like a 2-year-old needs to understand the urges of urination, but how to control them, how to recognize them, and how to appropriately relax the right muscles so that the urine can come out, and then appropriately tighten the muscles to prevent urine leakage when you don't want any urine to come out. Now, it's important to have periodic pelvic exams, and if you have any new urinary symptoms, it's important to get a simple dipstick urinalysis. This can usually just be done in a doctor's office or urgent care center, just to make sure there's not blood or pus or protein or things that shouldn't be in the urine that might reveal or suggest something more serious. One of the things that we do in our office is we have a post-void ultrasound that we scan the bladder before urination and figure out how much liquid's in the bladder, have the woman go and relax and empty her bladder, not trying to push it out, not trying to go fast, simply sitting and relaxing. And then scanning the bladder, and at least 2/3 should be emptied of the bladder. And I like to ideally see less than 50 cc's left of urine. And if it's 0, then we know you're able to completely empty your bladder, which is a good sign. If there's any pelvic growth or bowel problems, this can all affect the bladder. Weakness of the pelvic floor from back and hip injuries also can cause some problems. If there's any kind of prolapse of the pelvic organs or the bladder into the vagina or the rectum into the vagina, called a rectocele, these should all be evaluated. Now, we may want to recommend further stress testing of your bladder, like urodynamics, where we see how much the bladder holds of urine and how it functions.
We'll be back after a quick break.
Are you anxious about aging in the home? I know I am. For myself and for family members who need or will need care in the home. I've put together an informal podcast where I ask the owner of a home care company, her nursing leaders, and a variety of guests about how caregiving works in the home so that people can stay in their homes longer. We talk about everything from innovative thinking to basic tips in a conversational style that is optimistic. The podcast is called Keep Me Home Longer. Click on the link in the show notes or search for the podcast name, Keep Me Home Longer.
I had mentioned checking the urine for any kind of infection or urinary stones. An ultrasound can be done of the kidneys and the bladder and the ureters. Sometimes a more invasive test is needed that generally urologists or urogynecologists do, called a cystoscopy, where a very tiny tube with a camera is inserted into a numbed urethra to look inside of the urethra and the entire bladder. So after the cause and the evaluation of the problem is looked into to make sure that serious conditions are not overlooked, we get to the point of treatment. And for urinary urgency or overactive bladder, fluid restriction may be recommended, particularly after 7 p.m. at night before bedtime. Behavioral management, maybe keeping a log of foods and supplements to see if anything is irritating the bladder. Physical therapy with a therapist that specializes in the female pelvic floor with some expertise in biofeedback. So biofeedback is very, very interesting. There's many things you can control directly. Like if I say lift your arm up, you can lift your arm up. But if I say speed up your heart rate or slow it down, those are under the control of the autonomic nervous system, and you don't have conscious control. But with biological feedback of your systems, you can learn to control some of those. And it's the same thing with the bladder. Now, there are medications for overactive bladder. And over a decade ago, one of the medications, Ditropan, came over the counter in a 4-day patch that lasts for 4 days called Oxytrol. And it was available without a prescription. But I think anyone, before trying anything, should definitely have their urine dipped and have an exam. And some of the overactive bladder medicines may be definitely contraindicated if you have acute angle glaucoma or constipation. And some of these medicines do cause some dry mouth. Now, there are a lot of other medications that can be prescribed by a physician or APP. In severe cases, sometimes sacral neuromodulation or even percutaneous tibial nerve stimulation may be used. Sometimes bladder pacemakers can be used, and in cases where the bladder is so hypertonic and hyperactive, injections of Botox to relax the muscles can be done. Now, that can be painful and expensive, so again, lifestyle and medical management and physical therapy are generally preferred options. And the sooner you get on your bladder problem, as opposed to letting it really become such a problem that you're an adult depends, the sooner it's dealt with, the better. Now, for stress incontinence, there's a lot of non-surgical treatments. The first thing is Kegels. And I recommend that all women essentially do Kegels twice a day when they're standing up, brushing their teeth, and flossing. Some women say, oh, I do it on the elevator. Oh, I do it when I'm driving a car at a stoplight or stop sign. But you're not always in an elevator. You're not always in a car. But hopefully you at least brush your teeth twice a day, and you can do it then. And if you don't know how to do Kegels, and about 10% of women really just don't know how to do them, you can be instructed usually by your women's health professional who's examining you in the office. However, some people do need further instruction and really do need physical therapy referral. In 2014, 10 years ago, an over-the-counter disposable non-absorbent product became available to women to purchase over the counter, similar in design to a tampon, but not absorbent. And it kind of lifts up the bladder neck. It's put in like a tampon, 3 different sizes that really have to do with the firmness of it. And it's called Poison Pressa. And there's a starter pack with size 1, size 2, size 3. They're not necessarily bigger, they're just firmer. And it's like a disposable pessary. But it's not a fix. It's kind of like a Band-Aid. But sometimes that can be helpful. If you're jogging in a marathon, you're going to a funny movie, you're going to your grandchild's birthday party, and you are going to jump on a trampoline. It's nice to know that you have these options. But it's important that your vagina is not thin and dry from lack of hormones before putting something like that in the vagina. Another non-surgical option is to be fitted for a pessary, which is a vaginal ring that supports and lifts up the bladder neck. Pessaries can be used in women with pelvic prolapse who don't want surgery. There can be bulking agents injected near the urethra to give a little bit of support. And certainly I frequently will recommend vaginal DHEA, which boosts estrogen and testosterone at the genital level, and the testosterone helps the muscles. The estrogen helps thicken up the tissue of the vagina. And another option that I previously used years ago very frequently is a little vaginal ring about this size that you squeeze, push up at the opening of the vagina, called a string, ESTRING. It's pure estradiol, and it's released locally into the vagina without any effects on the uterus or the systemic bloodstream. And so both vaginal DHEA and a string can be used essentially in any woman, breast cancer survivors, women, who have otherwise may have a contraindication to using systemic hormones. And right now, we don't have the vaginal DHEA available in a ring, a silastic ring. I thought about studying this years ago, and when I went online to try to get a patent, I saw that someone had beaten me to the punch, and there's phase 3 studies going on in Europe. So I hope at some point we have a vaginal ring that's firm enough, but still comfortable enough to be put in the vagina without being felt, but enough to give a little bit of a lift. Now, about 10 years ago, some electrical stimulators came on the market from In Control Medical, which were inserted into the vagina and gave 2 different wavelengths of electrical stimulation. One, a strong enough wave to cause a Kegel stronger than the person themselves could do, and a second sensation of a lower vibration, which is at the same wavelength as what some of the interstim devices that are implanted to do. And certainly putting something in the vagina to stimulate the pelvic floor, or in the rectum if there's rectal incontinence, or if it's a male patient without a vagina, of course, then that can give direct stimulation without any kind of surgical intervention. But at the time that I'm recording this, unfortunately, the company that makes those were not able to get microchips, and everything else was made in the United States, but without the microchips, the devices are not being made. And as far as I know, my patients aren't able to get these. But prior to that, I pretty much recommended anybody with a vagina get one, particularly anyone with symptoms. Or I actually got them as Christmas gifts for people I knew who were having bladder leakage. Very happy to have that system, that problem cured. I also gave one to my daughter-in-law, who's a nurse, who's the mother of Artemis and Beatrice, because I knew with pregnancy and childbirth, I knew she'd have good-sized babies because she's married to my son, who was a big baby and a big guy. And, 6 weeks postpartum, doing the Kegels, or, once you get the go-ahead to put something in the vagina, putting the electrical stimulation really helps strengthen up the pelvic floor. And I remember a few months after she had Artemis, she said, Mimi, should I just stop jogging? Because when I do, I leak. And I'm like, have you been using your Attain device? No. Well, why don't you use the Attain device and rehab that pelvic floor so that you can do physical activities? But certainly any jumping or spiking, age and gravity are things that we all have to fight and aren't going to go away. And that certainly is true in the arena of the bladder. Now, sometimes surgical options are needed, and that's kind of not always a last resort, but it's usually something people don't just want to jump right into. And surgery can be done through the vagina or abdominally. And a woman's own body tissues can be used. There can be a small piece of mesh tape used. There can be suture that provides support at the base of the urethra. And women who have previously had surgery for stress incontinence and that's failed, there is some interesting research going on using a woman's own muscle cells to help regenerate the tissue. And in a future podcast, I hope to be interviewing the research team that's doing this research, because anyone who suffers, from leakage, particularly if they've done all the therapies and they've had surgery and it's failed, these people need new options and need help. Now, surgeries can be performed in isolation, but they're often done in combination with surgery to correct pelvic prolapse. And all women should be informed of all options: prescription, non-prescription, medical, surgical, physical therapy. And there's a lot of information on surgical options on the American Urogynecologic Society, which we'll put in the show notes. And we can also put in the show notes the study that's being done on women who've previously failed surgical corrective therapy. So everyone should know how to do Kegels, and I'm going to go into that in some detail, as well as more information on physical therapy. And you've been listening to the Speaking of Women's Health podcast with your host, Dr. Holly Thacker, in the Sunflower House, and we're talking all things bladder, all things urinary leakage, and how to do the pelvic floor exercises correctly. So at your next exam, you should ask, are you going to check to see what my pelvic muscle strength is? Because that should be done. You should get an assessment of your pelvic tone. And all women should be taught to do these exercises prior to pregnancy, during pregnancy, and after pregnancy. Unfortunately, this is not usually the case, and it's so simple and so easy, and it's important to get that feedback that you know how to do them correctly, because usually childbirth is a trigger for urine leakage, and you need to isolate and find out the right muscles. So you can imagine that you're sitting on a marble and you want to pick up that marble with your vagina. So visualize pulling, sucking, or drawing that in. You want to try not to squeeze other muscles. Don't tighten your abs or your legs or your buttocks, because squeezing the wrong muscles can put a lot more pressure on your bladder. Don't hold your breath, and don't be doing this while you're urinating, because that will confuse your bladder. Repeat it twice a day, but don't overdo it. You want to concentrate. You want to pull the muscles in and hold for a count of 3, and then release, and gradually work up to 3 sets of 10 repeats. It's easiest to do this exercise when you're laying down, like when you're getting a pelvic exam, but this is so easy that your muscles aren't working against gravity. So in general, that's why I recommend women do them when they're brushing their teeth, because it's like adding extra resistance weight to your workout. Be patient. Don't give up. It just takes a few minutes a day, and your dentist will be happy, because you've got to take care of those teeth and gums, don't you? And you might not find improvement in the first 3 to 6 weeks, but most people do notice improvement. It's also important to have regular bowel habits and not strain and not have hard stools, because correcting constipation can certainly help bladder function. Now, if you have an overactive bladder, you might need to take out irritants from your diet, like caffeine or citrus, B-complex vitamins. There's a long list that we have on our website of bladder irritants. Now, biofeedback. I got very interested in biofeedback when my oldest son, Stetson, who's been a guest on this podcast, developed panda syndrome after strep throat, which is a pediatric autoimmune neurologic condition that's associated with overactive bladder and some tics. And it got to the point where he had a hard time going to sleep because he had to keep jumping up and going to the bathroom. And I'm thinking, wait a minute, I thought this was a problem that older women had, not little boys. And I had to take him to a lot of different doctors and urologists. And And I was the one, his mother, who had to figure out what it was. And one of the treatments was, of course, obviously treating strep throat effectively, to reduce the autoimmunity and boosting B complex and vitamin D and helping the immune system, and then retraining that whole pelvic floor with biofeedback, which, because he's a boy, the probes can only be inserted rectally. But we had an excellent pediatric staff member, Dr. Benez, and I took him for biofeedback, and just a few sessions helped him relearn to retrain that bladder. And so he didn't have to take the overactive bladder medicines, which cause dry mouth and constipation, and his bladder could be retrained. And I found this very, very effective. And most of my patients that I refer for pelvic biofeedback, with or without electrical stimulation, find improvement with both stress incontinence and urge incontinence. Now, neuromodulation for urge incontinence that's not responding to behavioral therapy, drugs, treatment of vaginal atrophy, sometimes the nerves have to be stimulated. And the FDA has approved a device called InnerStim. And before having this done, I think you should evaluate all the other options. And if that over-the-counter pelvic stimulator through the vagina or rectum that can give the same wavelength of stimulations available, I think that's better than an invasive procedure. But I have certainly seen many women's lives significantly improved by the implantation of an InnerStim device. Now, in terms of injections for stress incontinence, using bulking agents like coapatite or carbon spheres can be injected around the urinary sphincter. This needs to be done by a doctor who's expert in this area. And that can help. It takes about an hour, but over time, the body can slowly break down these bulking agents, so repetitive injections might be needed. Now, surgery for stress incontinence can be undertaken where the urethral neck is supported. And surgeons have developed many different techniques. The three main types are retropubic suspension, and then there's two different sling procedures. Other tips to manage incontinence is that some women might use pads or liners, but I like to try to avoid that if at all possible, to not get used to just peeing in your pants, so to speak. Some people find that by reducing certain liquids like bladder irritants like alcohol and lots of caffeine from coffee or tea can be helpful. Sadly, most women are just embarrassed and don't want to mention the problem. And I think it should just be routinely asked about. And it's important to realize that just because it's so common, it's not a normal part of aging. And I know there's a lot of commercials about sexy absorbent underwear or adult diapers or liners or underwear that's absorbent. But this using, these type of diapers and liners, the practice, sometimes it's absolutely necessary, of course, but in general, the practice is really kind of unfortunate because diapering can lead to diminished self-esteem in an adult. It can irritate the skin. It can cause sores. And so if you're solely relying on this as the only option to manage your bladder, you should definitely be seeing a urologist and working with your family physician and looking at different treatments such as time voiding and pelvic floor therapy. I do want to spend a little time talking about vaginal pessaries. And there's a great column that we posted a few years ago by a urogynecologist, Dr. Shannon Wallace. So I would encourage you to go on speakingofwomenshealth.com and look at that article. Pessaries are excellent low-risk treatments for pelvic organ prolapse and sometimes can help incontinence. It's a soft, removable device. It's kind of similar to a diaphragm, which is a contraceptive device. It's generally a little bigger or firmer. and it's inserted into the vagina, and it supports the areas around the bladder and kind of lifts up the pelvic floor and rectum. It can help if you've got the kind of leakage that happens when you cough or sneeze or laugh, and it can compress the urethra during activities that otherwise might cause bladder leakage. Not everyone can be successfully fitted with a pessary, but about 85% of women can. And allowing you to be active and comfortable without having to go to surgery is something that many, but not all women desire. Some women want surgery. So there's a lot of different shapes and sizes. Most of the pessaries are made out of silicone, which is a harmless, soft, non-absorbent material. And it can be a ring shape, a donut shape, a gel horn, or a cube pessary. So you really need your healthcare clinician to pick the right one for your anatomy. A ring one is usually the easiest, and as I mentioned, the string vaginal ring can kind of serve as that, as well as local estrogen. The donut pessary is larger and is used for larger prolapse, but it can be challenging for the woman herself to insert and remove. And we have a great group of nurse practitioners who do pessary management for patients. Now, the gel horn pessary is a disc-shaped one, kind of is like a gel horn with a small knob, and it's used for more advanced stage prolapse in women who are not sexually active. And it's too difficult really for the woman to manage herself. So if you have one of these, you have to come back to the gynecologic office for periodic removal and cleaning. A cube pessary is used for very advanced stage prolapse. And the cube pessary forms like a suction inside the vagina to treat the area affected by prolapse. And again, you would have to come into the office for management of this. So in terms of wearing a pessary, your doctor will, of course, perform a vaginal exam and take measurements to fit you properly for the pessary. Just like if you're going to have clothes designed for you, you go and get measured because we're not all the same size. And it's nice to get the fitting done during the office visit, allowing you to leave the same day with the pessary. Sometimes it does take a few tries, just like sometimes you have to go back for alterations in your clothes. If it's too big, it's going to feel uncomfortable. If it's too small, it can fall out. In general, the pessary should be comfortable and you should not feel it. Occasionally, it might shift down towards the opening of the vagina, and you can use your fingers to push it back up. If you have a pessary and you need your doctor to remove it, you need to come in every 1 to 3 months to have it cleaned and reinserted. And most women with pessaries see their doctor at least once a year, usually sometimes 3 to 4 times a year. So what should you know about having a pessary? Well, there can be some increased discharge. If anything that changes or there's an odor, you'll need to come in and be examined. If there's any bloody discharge, that needs to be evaluated. Many times your healthcare clinician will prescribe moisturizers or local estrogen or vaginal DHEA to help thicken up the tissue. If the tissue's thin and raw, you can get ulcers or sores. You also need to let your healthcare clinician know if you're sexually active, and because we want you to be comfortable when wearing a pessary and having sex, and this can affect the type of pessary that is selected. There are pessaries that can be removed for sexual activity and then reinserted by the woman herself afterwards. So thank you so much for joining me on this episode of All Things Bladder and Urinary Incontinence. And thanks to our listeners for tuning in. And if you don't already subscribe to our podcast, please hit the follow or subscribe button. It's free. Please share this podcast with your friends and go on your app and give us a 5-star rating, whether it's Apple iTunes or Spotify, TuneIn, wherever you listen to podcasts. And you can donate to our nonprofit, speakingofwomenshealth.com. And thanks again, and I'll see you back in the Sunflower House next time.